All right. Hi, everyone. I'm Dr. Elizabeth Volkmann, and I'm a rheumatologist at the University of California, Los Angeles, where I direct the Scleroderma program. I'm delighted to speak with you today about GI tract involvement in systemic sclerosis or scleroderma. And we're also going to talk about some exciting research in this area. So hopefully you can all see my slides now, and we'll jump right in because there's a lot to cover. I want to let you know that there will be time at the end of the talk for questions, so please feel free to write your questions in the chat, and then we'll try to get to all of the questions at the end of the talk. So the outline for today is we're going to review the symptoms of GI tract involvement in systemic sclerosis, discuss how we diagnose GI involvement, how we manage some of the symptoms, and then again, we're going to review some of the exciting new research in this area. So when we talk about GI involvement in systemic sclerosis, I like to show this slide because it gives you a sense of all the different parts of the GI tract that can be involved in SSC. So we typically divide into the upper and lower GI tract. So when we talk about the upper GI tract, and you may hear your doctor mention this terminology, what they're basically referring to is all the way from the mouth to the esophagus to the stomach. This is what we consider the upper GI tract. When your doctor talks about the lower GI tract, they're referring to the small intestine, the large intestine, and then the anal rectum. And then these numbers here in red are the prevalence of this particular region of the GI tract being involved in systemic sclerosis. And there is a range depending on the patient population you're looking at. But you can see, for example, that with the esophagus, up to 90% of patients with systemic sclerosis will have some involvement of their GI tract over the course of their scleroderma. The stomach is 10 to 30%. The small and large intestine is 10 to 50%. You can see up to 70% of patients can have involvement of the anal rectum. So again, for the individual patient, it can vary, but this is looking at overall populations of patients with scleroderma. And these symptoms, as many of you probably have experienced firsthand, are highly disruptive. They can compromise lifestyle, emotional well-being, quality of life, and they've even been linked to symptoms such as depression and anxiety. So let's jump right in. When we start at the upper GI tract, I like to start at the very beginning, the mouth. So what can happen to the mouth in scleroderma are a few things. Some patients, particularly those patients who have tight skin of the face, can develop problems with opening the mouth and the mouth not opening quite as large. There can also be changes in the salivary flow, and many patients can have decreased salivary flow. In addition, there can be blood vessel changes that can occur in the mouth. And then in later stages of scleroderma, patients can have tooth resorption. And I think you're going to be hearing from a dentist today. You may have already heard from them. So they're going to go into a lot more detail about the mouth than I will here. But in terms of the symptoms, some of these can manifest with difficulty chewing, if you have dry mouth, and even temperature sensitivity. What about the esophagus? Because again, up to 90% of patients will have esophageal involvement. And so oftentimes patients will have something called dysmotility. And this is where the muscles, the smooth muscles of the esophagus, are not contracting in the normal way they should. So it's more difficult for food to pass down the esophagus. In addition, it's very common for patients to have the lower part of the esophagus be very relaxed. We call this part the lower esophageal sphincter. And this is the part that separates the esophagus from your stomach. And normally the sphincter is closed, and when you eat, it will open to allow the food to pass through. But what happens in scleroderma is that it kind of stays relaxed and open all the time. So it's fine if you're sitting upright and gravity will keep the food down in the stomach, but the moment you lie back, you can get reflux of the stomach contents into the esophagus. We can also see the blood vessel changes happen in the esophagus, and then there can even be areas that are narrowed, and we call these strictures. So what would be some of the symptoms you may experience? Difficulty swallowing, acid reflux or heartburn, and even chronic cough. And this is something I want to spend a little bit of time on because oftentimes patients with scleroderma who may have an underlying lung disease, if they have cough, everyone will just assume the cough is from the lung disease. But in fact, a very common cause of cough, not just in scleroderma patients, but in the general population, is reflux disease. And so we often ask about specific things about the cough to help us pinpoint, is it from reflux or is it from the lungs? So if your cough is occurring, for example, after you eat or after you wake up in the morning after you've been lying down a long time, oftentimes this is more likely due to reflux. But there are situations where people can have cough due to both reflux and lung disease. I just want you to remember that cough is not always just from lung disease and scleroderma. What about the stomach? So this is another area of the GI tract that can be involved. Patients can have issues with emptying that's delayed. So essentially the food doesn't pass out of the stomach very quickly, and this can lead to the sensation of being very full very easily after eating. There can also be blood vessel changes, and I'm going to show you some pictures of this in just a moment. So the symptoms you may have are early satiety, so getting full very easily when you eat, abdominal distension after eating, in severe cases, nausea, vomiting. And with some of these blood vessel changes, if you lose blood in the GI tract, you may develop anemia or low hemoglobin. So this upper GI tract involvement is very important for doing diagnostic testing. So very often patients will complain of symptoms, and what I see sometimes happening is that a patient will complain of symptom and then a medication is given to treat that symptom. But that's actually missing a step. And the important step is to try to diagnose where the symptoms are coming from. So I'm going to go through some of the tests that your doctor could consider ordering for you to help pinpoint the cause of your symptoms. So for the mouth, we obviously can do a physical exam. We often do lab testing, and we look for specific autoantibodies, the ones listed here, the SSA and SSB. These are two autoantibodies that we often see in a disease called Sjogren's syndrome that can also cause dry eyes and dry mouth and is very often associated with scleroderma. We can do salivary gland ultrasounds to get a better picture of the salivary glands, and then dental evaluation is so important in patients and really should be done every 3 months. In terms of the esophagus, upper endoscopy is something that many of you may be familiar with. And this basically is taking a scope with a camera on the end and going through the mouth down into the esophagus, goes all the way through the stomach to the upper part of the small intestine called the duodenum. And this will give a visualization of the upper GI tract, and you can also take pictures and even do biopsies. Barium swallows also help in terms of looking to see if there's narrowings or looking to see how things move through the GI tract. And the manometry is something that, for those of you who have had it, may not have liked it very much, but it's very informative in terms of diagnosing problems with motility. And I'll show you some examples of this too. And then for the stomach, we can also do the upper endoscopy, as I mentioned, looking down with a camera. And then gastric emptying studies can give us a sense of how fast the stomach empties its contents. So manometry, this is something that I told you is very important in patients who have, let's say, reflux disease or difficulty swallowing. And what this is looking at contraction of the muscle. And so on the top part here, this is the upper esophageal sphincter. And this is the upper part of the esophagus, so closer to the mouth. And then as you move down, this is the lower esophageal sphincter. This is the part, remember, that I told you can become relaxed over time. So in a normal patient, you can see here on the left, they have good contractions all the way down. In scleroderma, it starts off good at the top, and then by the time you get to the lower esophageal sphincter, the contraction is not so great anymore. And this could be a sign of this hypotensive lower esophageal sphincter. And the endoscopy, some of you may have seen the pictures of your own endoscopy. And for those of you who have not, A is like looking down through the scope. And this would be what normal would look like. But in B here, this is what we call watermelon stomach. And this is where we get a lot of dilation of the blood vessels. Another term for it is GAVE. And these blood vessels can bleed. And this can lead to, as I said, anemia. Again, this is another example of these dilated blood vessels and just a lot of inflammation. So both of these tests are really important to have done if you have symptoms of reflux disease or difficulty swallowing. So how do we treat upper GI tract involvement? And in terms of the mouth, as I mentioned, the regular dental hygiene visits are so important, at least every 3 months, because again, you're trying to diagnose problems early to prevent them from becoming severe. So if you have, let's say, a dental carie, you'd rather get a filling and get it managed right away versus losing your tooth or having to have a root canal. Soft foods can be very helpful, especially if you have difficulty with chewing. And then sugar-free lozenges can be helpful in terms of stimulating salivary flow. And again, this is a brand that I like, Dr. John's, because their sugar substitute is called xylitol. And xylitol has been shown to help improve the balance of good bacteria in your gut and in your mouth, and it won't increase your risk of dental caries. It actually decreases the risk. And then frequent sips of water can also be helpful here. What about the esophagus? So we often give medicines that block acid production, proton pump inhibitors, things like omeprazole, or H2 blockers, things like famotidine. And really the reason we give this is because we get worried about the acid from the stomach coming up into the esophagus, irritating the esophagus and causing inflammation. If this inflammation is ongoing, it increases the risk of esophageal cancer. So a lot of times patients ask me, because they read in the news about the dangers of proton pump inhibitors, and there have been some studies showing that they could increase the risk of things like osteoporosis, but we always, with every medicine, weigh the risk and benefit. And so if you have significant inflammation of the esophagus from reflux disease, the benefit of taking the proton pump inhibitor may outweigh that risk. Also, the promotility agents can be very helpful, something like prucalopride. If you have the issue of dysmotility and if it shows up on the manometry, this is something that may benefit you. And then we do have medications that sometimes can help tighten that lower esophageal sphincter. If again on the manometry, it shows that yours is very relaxed. And one example is buspirone. And then there's a whole lot of lifestyle changes that many of you are probably very familiar with that help. So a couple of the things that can work very well is sleeping with the head of the bed elevated. So there's different ways to achieve this. You can get a wedge pillow, but sometimes patients will kind of fall off over the course of the night or it ends up on the floor. In these cases, adjustable beds can be helpful. Or if that's not feasible for you, I even recommend to some patients taking some bricks or some wooden platforms and putting them under the head of the bed just to create a little bit of angle that will help with gravity. You want to avoid eating for at least 3 hours before sleeping. So you don't want to be eating and then lying down right away. And then in some cases, we actually have to do surgery, and surgery is an option for severe reflux disease. This is something we often do for patients if they're awaiting lung transplant and have a lot of reflux disease. So this is possible for some patients. And then nutrition. Some of you may know that I have a big interest in nutrition, so I'm going to try to incorporate a little bit of that into this talk here, even though it's a big topic. But on the left here are things that you should try to avoid if you have severe reflux symptoms, because oftentimes these can trigger the reflux. And again, it's not for everyone, but typically for most patients with reflux, they can be bothered if they have fried food, red meat, coffee, hot spices, alcohol, citrus fruits, tomatoes, as well as vinegar, right? But there are also foods that may help in terms of reflux symptoms. And again, there's not a lot of studies on this, but this comes from like personal experience and also studying some Chinese medicine nutrition. So soups can be helpful, gluten-free oats, yogurts can also be very soothing, and they don't have to be from cow's milk. You can have non-dairy yogurts too. Avocado, spinach, cucumber, liquid chlorophyll. And if you were going to have a tea, chamomile tea is a nice tea in terms of cooling down this part of the GI tract and kind of moving things downward in the body. In terms of the stomach, the small frequent meals can be very helpful. And one of the dangers that I see in some patients who come to me and maybe they're seeing me for the first time and they have pretty bad GI disease is they get full so easily that they'll only eat one meal a day. And then they're full and that's it for the rest of the day. And this is actually not very good because number one, it's hard to get all the calories you need in one meal and all the nutrients you need. But also, if you're only eating one meal a day, your gut is going to slow down even more. Just the act of chewing and eating stimulates gut motility. So rather than having one big meal a day, you're better served by having 5 to 6 very small meals a day if you suffer from delayed gastric emptying or gastroparesis. The pro-motility agents can be helpful here as well. And then also, if you have anemia from blood loss in the GI tract, iron repletion is important. Sometimes people don't even realize they're anemic, but if you find that you're very fatigued or you have fatigue on exertion, it could be a sign you're anemic, and you'll want to ask your doctor to not only check your hemoglobin, but ask them to check your iron levels and other vitamins like B12 and folate. All of those can contribute to anemia. And then in terms of lifestyle, this is something that some of you may have already learned through trial and error, but if you're going to lie on one side of your body, you always want to lie on the left side. And the reason being is this is sort of the direction that the large intestine moves. If you lie on the right side, you're kind of going in the opposite direction of gravity, and that's oftentimes where people can wake up feeling bloated. So I know we don't always have control when we sleep over what side we lie on, but if you're just laying down to rest or to stretch, try to always lay on that left side. Listen to the signs, when you're full, right? And don't push it. You can always stop and then come back to your meal a little bit later. Don't feel pressured to eat everything all in one sitting. And then I often recommend to patients these gentle digestive walks. So after you eat, taking a little walk, it doesn't have to be vigorous, but you just want to take a little gentle walk. It'll help stimulate gut motility. And it's also a nice time to just kind of relax and reflect on what you've eaten. So now we're going to move into the lower GI tract. And so this is just an example of the anatomy. So we're talking about the small intestine, which are these small loops of bowel here. And there's a lot of them. And then you have your large intestine that kind of goes up and across and down, and then the anorectum. And so in terms of the lower GI tract involvement, when the small intestine is involved, a couple of things can happen. One is bacterial overgrowth, or you may have heard the term SIBO, small intestinal bacterial overgrowth. And this is where you get an overabundance of bacteria that we think can promote inflammation and cause symptoms in patients. Pseudo-obstruction is something where the intestines twist on themselves. And it's called pseudo-obstruction because it's not a true obstruction. A true mechanical obstruction is it's fixed. It's not going to reverse itself. But typically in pseudo-obstruction with rest and hydration, the intestines can often twist back to their normal form. So what would be the symptoms? When patients have bacterial overgrowth, they can have distension, bloating. It can affect the absorption of food. So patients can have malabsorption and weight loss. There can be changes to the stool smell and stool consistency. And then with pseudo-obstruction, it can be pretty severe abdominal distension and bloating to the point where patients can't even pass gas. And then the large intestine, you can have dysmotility there, and usually it's slower transit, but it's different for every patient. You can also have malabsorption, and the symptoms can be diarrhea, constipation, even fecal incontinence. And I would say that oftentimes patients will have one predominant symptom. So there'll either be a lot of constipation intermixed with a little bit of diarrhea, or the other scenario, more diarrhea and a little bit of constipation. And when we talk a little about the treatment, I'll explain to you why that often happens in patients. So how do we diagnose lower GI involvement? So for the small intestine, you can do breath testing, and this will help diagnose bacterial overgrowth. You can do a CT or MRI enterography. This will help to visualize the small intestine. And then, as I mentioned, when you do that upper endoscopy, it only goes to the first part of the small intestine. But to get to all that other part, we can do video capsule endoscopy. And this is where you swallow a capsule that has a video that will take pictures for us so we can actually better see the small intestine. We sometimes do this when we're trying to find a source of bleeding in patients where we can't find it either on upper endoscopy or colonoscopy. So speaking of colonoscopy, for the large intestine, this is going up through the rectum, so the other direction to look at the colon. Colonic scintigraphy is looking at how the colon moves, so the motility of the colon. And then again, we can also do wireless motility capsules to look at how the colon is moving. And then finally, the anorectum, because again, this is a troubling area of GI tract involvement in many patients, but there are tests that should be done if you have involvement of their anal rectum. And again, the most common symptom would be fecal incontinence. So anal rectal manometry, you can have ultrasound or MRI of the pelvis, and this can diagnose if there's atrophy or weakening of the muscles there. And then surface electromyography also looks at the nerve connection to the muscle. So this is an example of an X-ray of a patient with scleroderma, and there's a couple of notable things here. So this is looking straight on at a person, so you can see the spine here and the pelvic bone, and these large dilated loops of bowel show that there is definitely an obstruction in this patient. Normally you wouldn't see all this gas. So that's what this is here. These white arrows at the bottom, this is just interesting. This is calcium that have been deposited in the iliac crest, so the hip bone. And as many of you know, calcinosis can happen in patients with scleroderma. And then finally, these dark arrows here are just showing the bottom part of the lungs. And you can see here that there's some fibrosis or scarring in the lungs. But the main reason I wanted to show you this picture was just to show you what an obstruction could look like. So if you have the concern that an obstruction is going on, this is definitely an emergency. You want to call your doctor right away, and they should get an X-ray as the first step to make sure that there's not a true obstruction. Okay, what about the colonic transit studies? Because I mentioned to you that many patients with scleroderma can have delayed colonic transit. So what happens in these studies is you ingest something that's radio labeled. So we're able to actually see how it moves through the colon. So on the left panel here is a normal patient, and you can see that it's all lit up at 24 hours. So it's moving through the colon. And by 48, you see kind of less of it. And then by 72 hours, there's nothing there. It has completely emptied out of the colon. But in patients who have slow colonic transit, you can see that at 24, 48, and even 72 hours, it hasn't completely emptied. So again, at 72 hours, you see complete emptying in someone with normal transit. And then if at 72 hours is incomplete emptying, this is a sign of slow colonic transit. And this often happens in patients with scleroderma. So how do we treat this? So for the small intestine, if you suffer from SIBO or bacterial overgrowth, there's some things that you can do with your diet that can be helpful. And one is you want to reduce your sugar intake and simple carb intake. And simple carbs are things like bread and pasta and pastries. All of these things, those bad bacteria that overproliferate in bacterial overgrowth, they kind of like flourish if you feed them those types of food, because right, the bacteria is helping digest your food. So if you reduce those, you can reduce a lot of your symptoms. Sometimes we even have to use antibiotics like rifaximin when you have really bad SIBO flares. Now, I would just caution you that I don't use a lot of chronic antibiotics in patients with SIBO. I try to reserve it just for those flare-ups. And the reason being is that chronic use of antibiotics will actually further disrupt the balance of gut bacteria you have in you, and it could make you more predisposed to bacterial overgrowth in the future. So really, these should be used sparingly and not every single day. And then foods that are rich in probiotics, I'm going to go through some examples of that, can help with that bacterial balance. For the large intestine, pro-motility agents or medications can be helpful, particularly if you have the slow transit, constipation, and then laxatives. And this is a lot of information for one slide, and maybe you want to take a picture or a screenshot of it. But the reason I wanted to put this up here is there's a whole lot of treatments for constipation. And I think as a society, for some reason, laxatives are kind of negatively viewed, or you really shouldn't use them. And the thing is, when you have scleroderma, you want to be having a bowel movement every day, right? This is normal. You need to release the toxins that build up over the course of a day. So you may have to rely on laxatives, and that's okay. So I don't think you should feel stigmatized because you have to use laxatives or embarrassed at all, because it's so important for you to have a daily bowel movement. And I will tell you, because I'm really interested in the gut microbiome, I was just reading this interesting study where they looked at patients with chronic constipation who had imbalance in their gut bacteria. And half the patients, they just followed them, and the other half, they put on a bowel regimen with a laxative. And actually, those patients who got started on the laxative had improvements in their gut bacteria. So it's really important. The other reason I wanted to show you this slide is to show you how all the different treatments for constipation, and some of you may have even tried, they work in different ways, okay? And so you want to be somewhat familiar with how they work, because it's going to matter in terms of the effect it will have on you. So there's a few here where it talks about softening the stool through increasing osmotic pressure. And what this means is these medications draw water into the GI tract to help soften the stool so that it will pass more easily. But if you have this very slow transit constipation where things aren't really moving well, you can actually end up getting more distension when you have these osmotic laxatives, because the stool softening alone is not enough. You really need to add on a stimulant laxative, like something like Senna, Bisacodyl, Prucalopride. And sometimes we have to use a combination of these. So just again, keep in mind that it's okay to use a laxative when you have constipation with scleroderma, and you may have to experiment with trying different laxatives or different combinations. It may change over time. It also may change in terms of what you ate the day before, but it's okay to use this. And I would work really closely with your rheumatologist and gastroenterologist to help find the right regimen for you. Other suggestions, so again, diet is something that's very specific to individual patients, but there's kind of broad suggestions that we can make that might help your experience with scleroderma GI symptoms. And one big one is to try to avoid ultra-processed foods. What this means is foods that have undergone some kind of chemical processing, either adding additives or preservatives to prolong the shelf life or change the flavor or color. There's a lot of evidence that these types of things can disrupt the balance of gut bacteria in your body. So this would be things like processed meats, like hot dogs, bacon, potato chips. A lot of the frozen meals are highly processed. And if you're not sure if something has undergone processing, a good way of knowing is to look at the label. So if something comes in a box or package, those are usually the most likely culprits of being processed. And then read the ingredients. And if there's less than 5 ingredients, it's probably not very processed. But if there's more than 5 to 10 ingredients, it's likely a processed food, especially if some of the things on that ingredient list are things you don't even know what they are. They're chemical names, you've never heard of them. These are things that you want to avoid. So I like this idea of looking at things with less than 5 ingredients, because this is more a sign that you're eating the more whole food, and this is better for your gut microbiome. And again, avoid those added sugars too. The probiotics. So there's a lot of different ways to get healthy bacteria, and some of the is through food, right? So if you have cultured products, and it could be like things like yogurt, it could even be things like pickled vegetables, but there's a lot of way to get probiotics naturally without spending money on an expensive supplement. And then prebiotics. This is also example of what bacteria, the healthy bacteria, like to feed off of. So things like jicama, asparagus, Jerusalem artichoke. Basically, prebiotics are these indigestible fibers that the good bacteria will eat, and it will help them proliferate. And again, some of the things on the list you may not be able to tolerate, or some you have to cook well, but just try to keep this in mind. These are going to be foods that will help balance your gut bacteria. And then what about the anal rectum? Because again, this is an area where oftentimes patients aren't even comfortable talking about their symptoms, so they don't even talk about treatments with their doctors. But there are some things that can be done. I usually start with physical therapy for patients, and specifically physical therapists that specialize in the pelvis. So you want to find someone that knows about strengthening the pelvic floor. And there are a lot of physical therapists out there that do this type of work. And they're usually very passionate about it because they, got inspired in some way to work with patients with scleroderma or other patients like who've had GYN surgeries. Anyways, they're really knowledgeable therapists. And if you don't have one in your area, you can also go online, and a lot of them now are offering virtual consultations. They can develop a strengthening plan for you that you can do at home. Sacral nerve stimulators could be helpful if the issue is the nerve not stimulating the muscle properly, and I'll show you an example of this. Sometimes we have to use antidiarrheal medications when you have fecal incontinence, and these just have to be used very carefully because we don't want you to take too much of them and then end up with the problem of having severe constipation. So those should be really used sparingly. These are things like loperamide. And then biofeedback has even been demonstrated to be helpful in patients with scleroderma with anorectal involvement. So this is an example of a sacral nerve stimulator, and you can see this small part labeled number 2 there gets implanted under the skin right near the sacrum to help stimulate, and this can be helpful for some patients. All right, so I wanted to save the remainder of the talk for going through some of the exciting research in this area because I feel like in scleroderma, and you may have this perception as a patient, that a lot of the research and clinical trials are all about lung disease and all about skin disease. But actually, the GI tract is an area where there's a lot of exciting research going on. And I think one of the reasons we've been a little bit delayed in terms of not doing a lot of clinical trials in this space is we're still trying to identify what is the best way to measure improvement. So for example, when we do clinical trials in lung disease, we have the pulmonary function test and we have the CT scans, and this gives us a sense of how the lung disease is improving. We don't have a lot of great outcome measures yet for GI involvement, and this is, again, an evolving area of research, and why it's so important that we do this research in this area so we can address this important complication of scleroderma that affects so many patients. So one concept I'd like to introduce you to is this idea of smooth muscle atrophy. So all along your gut, you have muscles that contract to help move the food through the intestines. And these are called smooth muscles. It's different than the muscles in your arms and legs, which is skeletal muscle. And, there's different ways the smooth muscle can atrophy or weaken. And so I wanted to show you some of the examples in scleroderma about why we think this happens. So just on the left here, we think that there might be some issues with the nerve. So the yellow here is meant to represent nerves stimulating the muscle. And if you have a neuropathy or problems with the nerves, it's not going to stimulate the muscle. And if the muscle isn't stimulated to contract enough, it's going to start to weaken and atrophy. The same in terms of the blood vessels. This was represented here by these red lines. All of you are probably familiar with Raynaud's and the blood vessel changes that happen where you get spasm of the blood vessels and lack of blood flow. Well, this doesn't just happen in the hands. There's evidence that it happens in other areas of the body too, including the GI tract. So you can imagine that if your muscles aren't getting adequate blood flow, they're also not going to be able to thrive and grow in the way that they should. This is why I always recommend to patients that when you're eating, you want to make sure you're warm. If you're cold, you're more likely to get vasospasm, not just in your hands, but in other blood vessels too. So you always want to eat when you feel warm. What about the bottom part here, this collagen fiber deposition? So there's also evidence that fibrosis can happen in the muscle too, and this could make it stiffer and less able to contract. And then finally, a very exciting area that we'll talk a little bit about is this inflammation part. And there's evidence that specific autoantibodies that are represented here could potentially help interfere with some of these processes and may play an important role in the pathogenesis or what causes GI disease in scleroderma. So let's talk a little bit about the neuropathy, and I don't want you to get too consumed with all the different parts of this figure, but basically what this figure is an example of a neuromuscular junction. And what this is when a nerve, which is represented here by this blue, secretes things, neurotransmitters, this is ACH is acetylcholine, that then binds to receptors on the smooth muscle, which is pink here, and tells the muscle to contract. So what has to happen is this has to be released and it has to bind to these receptors, and it says, okay, now contract. But there's actually been the discovery of what's called autoantibodies that bind to and block up these receptors so they can't be stimulated properly. And so this is our cartoon of that same picture there, where again, you get the release of the acetylcholine, but this red thing here is an example of an autoantibody. And you can see what it's doing. It's binding to this receptor here. So these acetylcholine little dots can't bind to the receptor and stimulate contraction. And so there's been some nice work by my colleague, Dr. McMahon at Johns Hopkins, looking at some of these autoantibodies and demonstrating that they can be associated with GI symptoms. So this is super important because it helps us understand not only what causes the GI symptoms, but it also gives us a potential treatment target. Maybe we can do something with the medication to help block those antibodies so they don't get in the way of this important connection between the nerves and the muscle. Another thing that actually has emerged is our understanding of autonomic nervous system dysfunction, right? So your autonomic nervous system is essential for living, and there's two components to it, the sympathetic nervous system and the parasympathetic nervous system. So I'll talk about the sympathetic nervous system first. This is your fight or flight system. This is the system that gets activated when you're in danger and you need to run away. And so it tells your body to do things that will help you run away from danger. So it's going to tell you to dilate your pupils because you need to be able to see where you're going. It's going to relax the bronchi so you can get more air in your lungs. Your heart rate's going to be accelerated so you can run faster. But then when you're running away from danger, it's really not the time where you want to have to go to the bathroom or eat anything, right? You don't have time for that. So that part of the nervous system is going to kind of shut down. You're going to inhibit the salivary flow. You're going to inhibit the contraction of the gut and the bladder. So that way that doesn't interfere with your ability to get away from danger. The parasympathetic nervous system is sort of the opposite to this. This is what we call the kind of rest and relax side of things. This is when you're not in danger and you're actually in a calm and peaceful place and you need to nourish yourself. You need to eat. And so in this setting, you want the salivary flow to be stimulated. You want the heart rate to go down, right? You want to stimulate contraction of the gut so that you can help digest your food. And so I mentioned this for a couple of reasons. One, there's research now showing that there's some dysfunction of the autonomic nervous system in some patients with scleroderma. But also, when you're eating, it's really important that you're in a parasympathetic state. So you don't want to be eating food when you're, rushing from one thing to another, or eating in your car, or even if you're sitting down to eat and you're watching news that's stressful. That may not be the best state to be eating in because you're not in the full parasympathetic state. So try to just keep that in mind. If you find yourself, going to eat and you feel a little bit stressed, you might want to wait to eat, take a little walk, do a short meditation, whatever calms you down before you eat. But again, as I mentioned, there's some signs that there could be autonomic nervous system dysfunction in patients with scleroderma, and this could relate to GI disease. So this was an interesting study that they did where they measured orthostatic intolerance, and this is a sign of autonomic nervous system dysfunction. And what this basically means is that when you check orthostatics, it's when someone checks your blood pressure when you're sitting down or laying down, and then they check it again when you stand up. And normally when you stand up, you need your blood pressure to go up so all the blood can go to your brain so you can still be functioning. But in patients who have autonomic nervous system dysfunction, sometimes that blood pressure doesn't react in the fastest way that it should, and we call this orthostatic intolerance. So in this study, what they found is that patients who had higher levels of orthostatic intolerance were more likely to have significant GI disease. So this to me suggests that there could be a connection again between this autonomic nervous system dysfunction and GI symptoms in scleroderma. And again, it gives us another opportunity to potentially target a different area to help improve GI symptoms in patients with scleroderma. And then finally, this is an area that I'm very interested in, is the changes in the gut bacteria, right? So this is kind of a schematic of what you would expect. So in a eubiosis or normal condition, all these colorful dots here represent bacteria. And this is sort of represents the inside of the intestine, right? And you want a variety of bacteria that keeps things healthy. You can also see that the wall of the intestine, everything is tightly linked together. So really the only thing that's getting through are the nutrients, no inflammation, and it's a nice calm state to be in. But what happens in dysbiosis is you get this overabundance of certain bacteria that we think can promote inflammation. So this is represented here by these dark black circles, right? You don't see as much colorful stuff here. This is decreased bacterial diversity. And you get this overabundance of certain bacteria that we think cause inflammation. The other thing that you may notice here is that when you get this dysbiosis, other things happen downstream. So one is that, see how this lining here used to be so tight? Now you have some openings. So what's happening? Some of the gut bacteria are getting through. Sometimes their toxic metabolites get through. This can enter the bloodstream and cause more inflammation. So again, this could be a cause of some of the problems that we see in scleroderma and other autoimmune diseases. And we did the first study looking at gut bacteria in patients with scleroderma back in 2016. And we were able to do colonoscopies on patients and sample the bacteria in the colon. And we found that patients who had higher levels of certain bacteria had less symptoms. So for example, patients who had higher levels of Bacteroides fragilis, Clostridium, Blaudia, and Lactobacillus, these patients tended to have decreased symptoms. Conversely, there were some bacteria that when they were in higher abundance were associated with more symptoms. So Fusobacterium, Actinobacillus, Actinomyces, Ruminococcus. And I wouldn't get too caught up on these specific ones here, but all I want to demonstrate to you is that there is evidence that some of the symptoms could be related to the imbalance in gut bacteria. And we've taken this research further. So this was a study that we published this year. And we were interested to understand whether patients with early scleroderma, so within 3 years of their diagnosis, had changes in their gut bacteria. Because some people think, okay, well, maybe the changes in gut bacteria just happen because the gut slows down and the bacteria accumulate. But we actually looked at a population of patients before they got problems with their gut motility. So very early in the course of their scleroderma. And we compared them to healthy age and gender matched controls. And what we found were there were significant differences. So these are the bacteria names here. And the ones on the right of this line were higher in patients with scleroderma. And the ones to the left of the line here were higher in the normal healthy controls. And there were a couple here, Ruminococcus and this one here, Desulfilfibrio. These have been shown in other studies to be higher in patients with scleroderma compared with controls, whereas this Fusilibacterium was higher in the healthy patients. So again, there's evidence that these changes in the gut bacteria happen early. Also, in the same paper, we looked to see whether patients with certain features of scleroderma had alterations in their gut bacteria. And this is what we call a principal component analysis. Here we're looking at the overall differences in the composition of bacteria. And so in the blue here, these represent individual patients, and all of these patients with blue had interstitial lung disease. Whereas all the patients with red, were each a dot here, they did not have interstitial lung disease. And you can see that the red kind of clusters in one area and the blue in another. We found the same thing when we looked at people that were on any kind of immunosuppressant medications or not. So there's a whole lot more research that we need to do in this area, but I think this provides some evidence that the gut bacteria may be contributing to some of the GI symptoms that we see in scleroderma, and it may even be involved in other issues like interstitial lung disease. So to summarize, there's a variety of GI symptoms that can happen in scleroderma, starting at the esophagus with dysphagia, reflux, with the stomach, early satiety, bloating, bleeding, the small intestine, malabsorption, weight loss, the colon, pseudoobstruction, constipation, diarrhea, and then fecal incontinence, rectal prolapse. And I think when you see your doctor, it's important to tell them about the symptoms you're having. Again, they may be asking you mostly about your skin or mostly about your lung, but really you need to offer these symptoms because these are important. These affect your quality of life, and there's actual treatments that might be helpful for you. So speak with your doctor about your GI symptoms. Studies are important because they can help you identify the specific cause of the symptoms, and the treatment plans really require a multidisciplinary approach. So it's not just the medications, it's nutrition, it's lifestyle changes. All of these things could help improve your quality of life when you have GI disease with scleroderma. And I want to thank you for your time. We have about 15 minutes for a question. I also have an email address up here if you're interested in receiving a monthly email with information about nutrition and other things when you have scleroderma or even other autoimmune diseases. This is a service I provide to my patients, and I'm happy to extend it to all of you. All right, so let's go to the stop sharing. All right, so it looks like we have some questions already coming through, so we'll get started on that. So the first question is, have they found a relationship between celiacs and SSC? So celiac disease is a disease where people have a complete intolerance to gluten, and usually these patients have certain findings in their intestines, and they also can have certain blood tests that are positive. There was a study that was done looking to see if the rate of celiac disease was higher in patients with scleroderma, and in fact, it was not. There's no higher rate of celiac disease in patients with scleroderma compared to the general population. However, some patients with scleroderma and other autoimmune diseases have sensitivities to gluten. So you can have a sensitivity or intolerance to gluten and not have celiac disease. Good question. All right. I have silent GERD. I'm taking a proton pump inhibitor. How do I know it's working? This is a great question. And I would say that it's important. It looks like your doctor was being proactive in diagnosing the GERD, even though you didn't have symptoms. So we can do different things to track to see how well it's working. One thing is the endoscopy, the test that I mentioned where they go down with a camera and look at the esophagus. You can see signs of inflammation if the reflux disease is not well controlled. So that's one way that you can see whether the proton pump inhibitor that you're taking is working or not. Good question. All right. Let's see here. Can SSC patients have dysmotility in the large intestine and none in the small intestine, or would you have dysmotility in both equally? Another fantastic question, and actually I again have to reference my good colleague and collaborator at Johns Hopkins, Dr. McMahon, because she has really pioneered some of these studies looking at GI transit in different parts of the GI tract. And so you can actually indeed have slow transit in the colon, but normal transit in the small intestine, or vice versa. So again, my hope in the future is that we get better at doing this motility studies so we can really pinpoint the part of the GI tract that's affected. But I think importantly, if you're having these symptoms of constipation, you need to tell your doctor so they can do the appropriate test to figure out what the cause is. But again, a great question. Okay. My doctor has prescribed Bentyl for abdominal pain. Does this slow down my digestive system? It can, but it's different for everyone. So what I would do in this situation, in fact, I would do this in any situation, if you suffer from GI symptoms and you're starting a new medication that you're worried could affect your GI tract symptoms, I would right away start a diary. And I would do a diary of your symptoms every day for about a week before you start the new medication. And then you start taking the new medication and you keep doing the diary and see if any of your symptoms changed. And if you're really not sure, another thing that you can do is then stop that medication and then go back and see, oh, do my symptoms go back to normal? So this is one possibility for determining whether a medication is having an effect on your GI tract. And this is important because if you already have GI symptoms, you certainly don't want to add on a medication that's going to make those symptoms worse. Along with Senna, what were the other laxatives that not only soften but help with movement? So it's hard for me to go back to that slide there, but I think it's things like Bisacodyl is one of them, Prucalopride, and the brand name for that is Motegrity. If you Google stimulant laxatives, it'll usually bring up a pretty reliable list of things. So again, some patients only need the stimulant, or some patients need the stool softener, and some need a combination of both. But I think the important thing is to find that regimen that gives you a daily bowel movement, or at least every other day. This is so important for your health. So the next question, so does this binding inhibition mean that dysmotility might be mainly due to that and not due to extra collagen stiffness scarring? Yeah, this is another great question. So I think this question relates to what causes the dysmotility or the problems with the muscle contractions in the gut. I think historically we thought, okay, this had to be due to the fibrosis. And this was largely based on studies they did many years ago looking at autopsies, where patients who died from scleroderma, they would look at the intestines and they'd see all. Actually, there's more and more evidence that in some patients, there's not a lot of fibrosis or scarring in the gut. It's more an issue of the nerves that's not causing the muscle to contract well, or the blood vessels not having adequate blood flow. So I think, and it might be different for different patients. So this is, again, really important for us as researchers to try to understand, because some treatments might work better for some patients and not for another, depending on what's driving the symptoms. Okay. And then to follow up that, if so, does that mean that it might be able to be reversed someday with the right meds that enables the muscles to receive the signals again? Absolutely. And that's how some of these stimulant laxatives work, is that they bypass that normal way and they just say, okay, muscle contract, and they try to keep it stimulated. And I would say that these are better to be introduced early on, because if you have later stage GI disease and a lot of muscle weakness or atrophy, no matter how much you stimulate, if the muscle's weak, it's not going to be working that well. So I like to introduce these medicines early in my patients because, again, this can be helpful in terms of getting that daily bowel movement, but also keeping that muscle active so it doesn't atrophy too much. Is the motility test intrusive and done in hospital or as outpatient? So the one that looks at the whole gut scintigraphy, this is typically done in the hospital, but there are other ones like the manometry I mentioned that can be done outpatient. So it sort of depends on which motility test you're talking about. Is there anything that can be done to stop the reflux or aspiration permanently? I wish we had a solution. There are some patients who do surgery, and it's the only thing they need to do. But this typically isn't the first thing that we go for, because it is a highly invasive procedure and it doesn't work in every patient. But that would be the only thing I could think of that could completely reverse things. But usually the medicines that we give to patients help minimize the symptoms, prevent progression. But again, we have a lot more work to do in this area to try to find a cure for the GI disease and scleroderma. Another great question. I like this topic a lot. How much fiber do you need to have in a day if you have delayed stomach emptying? This is such a great point, because it relates to a lot of issues that happen in scleroderma. So if you were to just Google constipation, what would be the treatment, you would find on Google would tell you eat more fiber. And for the average American, fiber can do the trick, because the Western diet is usually devoid of a lot of good plant fibers that help keep you regular. But in scleroderma, that's not the problem. The problem is not the diet. The problem is that things aren't moving as well. So you have to be really careful about your use of fiber. If you're taking in too much fiber and your gut is not moving well enough, actually you can get more abdominal distension. So I really would be careful about adding extra fiber to your diet. And if you do so, you want to do something that you can kind of titrate. So I really like things like ground flaxseed, because you can start out with like a teaspoon added to something like your yogurt or your oatmeal, and then you can build on that and add more and just see how you tolerate it. I prefer the natural fibers than things like Metamucil, just because the Metamucil is full of additives and preservatives that might affect your gut microbiome potentially. Are there studies showing patient nutrient profiles, and are there any trends? There are some studies looking at deficiencies in nutrients, and we just published a paper looking at a review of all the studies that have been done looking at nutrient deficiencies in scleroderma. So there's evidence that many patients with scleroderma are deficient in things like vitamin D, but other vitamins too. And then in terms of, if you're talking about diets, we have a lot more work to do in this area too. But one of the diets that's commonly recommended for patients with scleroderma is the low FODMAP diet. So we're now starting to do research to see how the low FODMAP diet can affect the gut microbiome and symptoms in patients with scleroderma. All right, we're getting close to the end. So if you have any other questions, feel free to write them in the chat. This has been such an engaging group, and I just encourage you on your journey to think about your GI symptoms, to write them down, to keep a diary, to talk to your doctor about them, because again, this might be something that gets overlooked. And the last question here is, can stool fossilize in your body? What can happen in patients with scleroderma is that there can be impaction of stools. This might be what you're talking about, where it can become very hard, and the harder the stool gets, the harder it is to pass. And so that's definitely possible. And again, another important reason to stay regular through the day so that you don't get this impaction of your stool. Any other questions? Okay. If not, I want to thank you all today for your time and tuning in. This has been a really wonderful opportunity. And then last question, I sent a question earlier about using 1,000 milligrams vitamin C for constipation. Sorry, it wasn't a pinned message from me, but I can see it now. So thank you for asking it. I'm not aware of studies looking at vitamin C for constipation, but if it's something that helps you with your symptoms, then I would say continue it. I think the thing to be careful about with vitamins is that if you're taking a supplement, meaning you're taking more than what would be recommended just from the food you're eating, you want to make sure that someone is monitoring the levels of those vitamins in your body, because you don't want to end up with too high levels. This is happening a lot with vitamin D, where people are taking it as a supplement in excess and then ending up with super high vitamin D and getting kidney stones and other problems in their body, even constipation. So if you're taking a supplement like vitamin C, you want to make sure that someone's monitoring the level of that in your body. What kind of milk can you drink if you don't do dairy? There's so many options nowadays. There's, things like oat milk. You can have the nut milks like almond milk. There's rice milk, there's even soy milk. There's a lot of different options, and I recommend trying them out and see what flavor you like, because really your food should be something that not only nourishes you and helps with your overall feeling well in life, but it also should be something that brings you joy. So you shouldn't force yourself to drink, oat milk if it doesn't taste good to you. But if you like the taste of almond milk, you can try that. Or if you like them all, you can do a variety just to get different variation of the milk. What about Linzess or erythromycin? So these are also two things that have been done to help with constipation predominantly in patients. Erythromycin is not done as frequently anymore. It's an antibiotic, and so it can affect your balance of gut bacteria. And it also has been associated with different cardiac issues and in interactions with other medicines. So I would say it's kind of fallen out of favor. But Linzess is something that we do use. It was on the list there, just the generic name was on. This is something that, has to, again, be used judiciously, because if you use too much, it can cause diarrhea. So this is great. All right. Well, I want to thank you again for your time today. And if you want to, again, sign up for that newsletter, I think someone wrote it in the chat. And I hope that you all have a wonderful evening. Take care.